paper describes service delivery models in a number of different contexts, and in particular, we focused on the US, South Africa, and Eastern Europe. I'm going to speak about the US since that's certainly where I am the most familiar and do work myself. There were three things that we focused on. One is low barrier care. And this is specific to HIV, but certainly is a model that is and can be used with other chronic health conditions or patient populations as well. Low barrier care is really the idea of having care to access for people with complex needs who don't engage in more conventional healthcare. So there are examples of these clinics in several cities throughout the world. I work in one here in Seattle called the Max Clinic, and it has a few key elements. First is walk-in access to care. That is the kind of thing that I think makes the most difference and the most importance, is also one of the most challenging to do administratively. So drop-in or walk-in access to care. The second is having intensive social support paired with that care. And the third is having some incentives. So that doesn't have to be cash or gift cards. It can also be clothing, food, things that people need that make it worthwhile for them to come to clinic and attend to their health amidst all of their other competing survival needs. So low barrier care, especially walk-in care. The next and related to that is mobile services. So certainly that's something that's been used in HIV care and prevention. It's an area where we don't have a lot of research, and I think we really need better research into cost-effective models and how to have the right balance of clinic-based or facility-based care with mobile teams of people who go out to where people live or where they're willing to meet someone and deliver what services can be delivered in the field, usually with a goal of also bridging them to clinical care if possible. The third thing that we addressed was long-acting injectable medications. These really have enormous potential for changing the landscape of HIV treatment in the United States. They are still too difficult to get and not truly accessible to people who need them the most. And that's people who are not virally suppressed on oral treatment. For various reasons, it can be hard. It is certainly harder for people who are living homeless to take pills every day, and having an option to get an injectable treatment can really be a life changer for them. So those are the three key things: lower barrier clinic care, mobile services with a lot of work to be defined on how to do that better, and long-acting injectable treatment. I think low barrier care is the most promising because it's a flexible model and can be done in different ways in different systems. Even within a conventional HIV clinic, people can make time on certain half days of the week or with dedicated providers or with nurse-based models to have walk-in availability for patients. So I do think that's the most promising because it's the most scalable and flexible, and probably the most important for engaging this population of people who are homeless or unstably housed.